Kevin Doyle is the president and CEO of Hazelton Betty Ford Graduate School. In his 35-year career, Kevin has been a licensed professional counselor, clinical supervisor, professor, and nonprofit executive. But substance misuse disorders and mental health have been at the center of his efforts in each role. Welcome to the Science of Good, where we sit down with cause leaders who are disrupting the status quo, tackling our toughest societal problems, and seeking better ways to spark change. Welcome, Kevin Doyle. Thank you so much for joining us today.
It's my pleasure to be here. Thank you for having me.
Can you tell us what initially drew you to work in the field of substance misuse?
I'd be happy to, and I'm still trying to figure that out myself some days. I come from a family where it was instilled in all of us to help others in some way, and so I think the quest, if you will, for people, my siblings and myself, was to figure out, what our gifts were and how can we be of help to other people, and that had been modeled to us by a long line of teachers and nurses and just people who felt an obligation to help others, and so that was the job before us. And so I had an opportunity many years ago to go to graduate school, and it was in campus ministry. And part of the benefit for the campus ministry position was they would cover your graduate school. And I said, well, what graduate programs do you have? And the school had a counseling program, and it was no more scientific than that. I said, that sounds like an interesting fit. So I started taking counseling courses, and then I took a course in addictions, and I was fascinated. I just felt as if there were so many misperceptions out there and so much judgment, so much stigma. And then I started meeting people in recovery, and their stories are just overpowering, amazing, inspirational. And there was a part of me that, even though I don't identify as a person in recovery myself, that was just drawn to those stories. As I started picking internships and placement sites for my own counseling, academic training, I just gravitated to that, and it stuck. And it's been, 35 years now of working in that area. And I'm just I never cease to be amazed by the power and the transformational nature of what people in recovery are able to both overcome and accomplish. So, um, unlike many people back at that time, the workforce was largely people who had lived experience of addiction or in their families, and that really isn't my story. But I feel like I'm an honorary member of the tribe, if you will.
So, Kevin, Hazelton, Betty Ford, those are two very famous names in the recovery um, business that came together some years ago. Both of them were initially founded centered on the treatment of alcoholism. I know a lot has changed since then. Can you talk a little bit about the evolution of the clinical side of things, and then we'll get into the academic side as well.
Sure, absolutely. So, this is an important year in the history of those organizations. So Hazelden was founded in 1949. So this is the 75th anniversary of the founding of Hazelden in Minnesota, largely by people from the recovery community. And as you said, Kevin, at that time, mostly focused on alcohol. And over the years, it became clear that it was becoming um, less and less common for someone to present for treatment with only that particular substance in their history. It would still happen occasionally. It still does happen occasionally, but it's more and more rare. And so anyone providing treatment for folks with what we now call substance use disorder need to be adept in working with a variety of substances. Betty Ford Clinic, of course, the Betty Ford Center, founded by Mrs. Ford. Um, uh, about 40 years ago, and the merger happened 10 years ago. So there are all these milestones that have happened. And so Hazel and Betty Ford, the merged organization, now has locations in about 10 states, as we serve people from around the world on the clinical side as well, with more and more complex problems. And the latest evolution has been to be more inclusive of people with mental health disorders too, not just substance use disorders.
Hmm.
Well, congratulations on all of those milestones, and certainly congratulations on continuing to evolve. So, what drove the need for you to form a graduate school focused on treatment and counseling?
Yeah, thanks, Rashonda, for that question. So, in the early 1960s, around 1963, it became clear that no one was really training alcoholism counselors or addiction counselors. And so, Hazelden, at that time, pre merger, started the Hazelden Counselor Training Institute. And it was a year-long intensive training program that attracted people from around the world because nobody really was doing that. And even into my graduate education, which I consider to have been excellent, there still was very little knowledge around substance use. It's always sort of been off to the side a little bit. And so,
Mm.
as our training institute evolved in the 60s, 70s, and 80s, the field of treatment was evolving as well. And it became more and more important for people to have credentials beyond just a certificate that you kind of hang on the wall, literally. I mean, and I've met graduates of the Counselor Training Institute, and that's what they have. They don't really have a transcript per se, they don't have a degree. And so in the 1990s, it became clear that we needed to think about becoming more professionalized, if you will, as a school. And so the idea was to form a graduate school. And in another milestone, in 1999, that's when our graduate school was formed from the Counselor Training Institute. So we just celebrated our 25th anniversary. Um, and we're on the higher ed side now, and so that comes with all the positives and all the challenges, like accreditation and licensure and
Hmm.
all of the things, scrutiny by all kinds of regulatory agencies. But that's the country we live in, and so it bestows a certain amount of legitimacy on us as well. But that's the history over the period of time from the early 1960s to the present.
Kevin, earlier you mentioned stigma, and we work with so many clients who have stigma, who face stigma around the issue that they're trying to improve. Um, think about the courage that it took for Betty Ford to be very public in uh, in in addressing her own personal struggles, and the bravery that it took um, to have a very public facing uh, center and clinic named for her. Have you seen progress in recent years as far as the destigmatization of substance misuse?
I absolutely have. Stigma is alive and well and very powerful, but compared to when I got my first job in this field in 1986, I've seen dramatic progress. I think, you know, celebrities and well-known people in the public eye, Mrs. Ford may
Mm.
have been really the first to have the courage to stand up and say, "This is something that I need help with, and I'm getting treatment for," and to be open about that. But Simone Biles, for example, speaking about her mental health challenges recently during the Olympics, and there's such a long list of people in recovery from a mental health disorder, a substance use disorder, both, who have really courageously been open about that struggle and about the recovery process. So, um, although stigma is still important to address and very strong, from employment to barrier crimes to all kinds of ways, discrimination in terms of insurance benefits and parity, all those things are ongoing advocacy challenges. I do think it's far better than it was 3 or 4 decades ago, and hopefully that progression will continue. So there is hope and there's progress, but there's still a lot of work to be done.
You talked about earlier that a good portion of your students have a history of treatment and recovery from it. Do you believe that that lived experience really helps to make for a compassionate and capable counselor?
It can, but it is not the only way that someone can be effective in this role. And so I have immense gratitude toward people who have that lived experience, that recovery experience, and use that as a motivator. I think we have to
Mm.
be careful not to accept that as the same as professional training. And it sounds a little ludicrous to say this, but we would never say that your lived experience as a person with a mental health disorder or your lived experience as a person with a physical health disorder,
Hmm.
cardiac issues, for example, you still need
Sure.
the professional training to do the work well. But I do think that because it's such difficult work, bringing that passion is really important. And so people with lived experience have that almost universally. Not every person in recovery is cut out to be a counselor or a therapist or addiction treatment professional. the combination of that lived experience plus outstanding training can really produce an amazing clinician. So what I would like to see is a broadening of the workforce, adding people like myself who don't necessarily have that lived experience but are intrigued, saying, I'd like to be part of a solution here. Can I learn how to do this effectively? And complement those who do have lived experience, and really generate a powerful, robust workforce. That's the goal, and that's what we need.
I'm as with any medical issue, I'm sure there have been um, big advances over the years since the institutions that formed the school were founded. Um, Yet, my understanding is that the kind of 12-step program is really at the core. Is that still at the core? And what advancements have happened around that?
Yeah, great question. It is still at the core in many ways, but I think what we've learned to understand is that each person recovers somewhat differently. And so we have to be open to different approaches for different people. So we often say tailor the treatment to the individual, or more colloquially, meet people where they're at. That's what we like to say. And for whatever reason, the 12-step approach may not be the right fit for the individual patient or client sitting in front of you. So I've seen some great progress in recognizing that, as wonderful as the 12-step programs may be and are for literally millions of people, that doesn't mean it's the right approach for this person sitting in front of you on that day. One of the things that Hazel and Betty Ford is known for is embracing what have been called medication assisted approaches, or as a good friend and colleague of mine likes to say, medications for addiction treatment. So recognizing that whether it's methadone or buprenorphine or naltrexone or whatever the medication is, if outcomes are enhanced by the use of medications, we have an ethical and a moral responsibility to be open to that. And so at Hazel and Betty Ford programs, medications are woven into the treatment plan for particular clients and patients for whom those are appropriate. That's been a big change. And I think when medications came out, for specifically for addiction, but even when medications were used for mental health disorders for people who also had addictions, which we used to call dual diagnosis, now we say co-occurring disorders, there were a lot of longtime people in recovery who looked at those really negatively. And the stigma was there too, Rashonda, going back to your question as well, that, well, you're not really in recovery, or that's a crutch that you're relying on.
Mm.
And I think we've moved past that. We've looked at medications for mental health and substance use disorders as additional tools to simply saying abstinence is the best approach. Don't get me wrong, abstinence is a wonderful approach for people for whom that's appropriate, but we wouldn't dream really of saying, well, you have depression, okay, you need to go to a therapist and talk that out. That can be part of the treatment plan, but for many people, medication for a mental health disorder is essential. And I think we're starting to look at that with addiction or substance use disorders too, that we need to at least consider that, especially if someone has had multiple episodes of an abstinence-based approach, if we're going to distinguish that way, and never offered an opportunity for incorporating medications appropriately into that. Um, the number of overdose deaths in this country, I think everyone would agree, is completely unacceptable. It's still over 100,000 per
Mm.
year, even though it's come down slightly for the last year that we had statistics. And that's just the overdose deaths, not other deaths associated with addiction as well. So we have to be really open to a variety of approaches, trying to work with our patients and clients to figure out what's the best way to approach this for you as an individual. So whether it's alternative to 12-step approaches like refuge recovery, for example, is a Buddhist based a recovery fellowship that's based on Buddhist principles. Some people that could be a perfect fit for that. Smart recovery is another one, self-management and recovery training. And there are many, many of them. Um, my experience has been, if you approach a person respectfully, and for whatever reason that person says, I've had a tough experience with AA, let's say,
Mm.
hear that, understand that, explore that, offer some alternatives, be respectful of that person's point of view. And if you are, sometimes they'll find their way back to the 12-step programs anyway, as opposed to saying, this is the only way. And I say that with love and affection for the millions of people in 12-step recovery programs for whom that is just essential. Um, it is a great fit for many people, but having it kind of crammed down your throat and portrayed as the only option, I think, is irresponsible. So that's our job as clinicians, is to look at formulating a treatment plan for this individual person based on their background and some of their preferences and their life history up until that point. So long answer, but a really important question. I'm glad you asked it.
Kevin, what I hear you saying from that too is that it's not a one size fits all. We
That's
have to
right.
really look at the person individually and see what works. And even in your response to that, to our question, you talked about and you mentioned 100,000 overdose deaths in the US every year. 100,000. I suppose that opioids do play a key role in those tragic statistics. So, are you all making any progress on the opioid epidemic?
I think progress is being made. The numbers right before the pandemic had really gotten national attention, and the federal
Mhm.
government and state governments were starting to mobilize around that. And then, of course, COVID really caused us to shift our focus a little bit. And so the numbers have just now seemed to be starting to come down again. So I think there's progress. Everything from the opioid overdose reversal medication Narcan, that's more readily accessible. You see that now in first responders and a lot of places they're available. You can get training and carry it with you. I have one of the a Narcan kit in the glove compartment of my car. So you hear about people whose overdoses are being reversed. So we have the medication that can do that. So there's progress there. Access to treatment, of course, access to medications as part of the treatment process. I think those things are improving. Um, but gosh, we need to mobilize around this and do much better. So yes, again, sort of like with stigma, there is progress, but there's still a boatload of work still to be done.
A long way to go, and part of that, I'm sure, um, is you're managing to recruit new students. I have to think that having such famous names in front of your school has to be a tremendous aid in adding sort of an instant credibility and respect and high regard for the names Hazelton and Betty Ford. But I'm sure at times, from a marketing perspective, it can be almost overshadowing. Can you talk a little bit about how you address that, um, both blessing and possible, um, unintended outcome?
Yeah, it is a great benefit, of course, to have the Hazel and Betty Ford name in front of our school, and that's how many people find us and are attracted to us. So we're so grateful for that, and we hear that from our students all the time. That why did you choose us? Well, of course, Hazel and Betty Ford. That's why I chose to come to the organization too, the graduate school. I think I had a vague awareness that we had a graduate school, being from the East. But I'll use a sports analogy here. It pains me to use it because I'm not a Yankees fan, but I've said, when the Yankees come calling and you're a baseball player, you kind of have to listen. And for me, even though I wasn't living in that region of the country, when there was an opportunity to come to the school as the dean of Hazel and Betty Ford, you kind of have to listen. It's just kind of the same idea. And I'm not a Yankees fan, so that's a stretch for me to even say that. But um, so that certainly our students, are drawn to that. I was just looking on the leading counselor education accreditation website the other day, and there are only 20 accredited addiction counseling tracks by KCREP. That's the accrediting body in the entire country. So not many places specialize in this. It is our specialty area. We are known for this. And so on balance, I think, Kevin, it's a tremendous benefit to us, as opposed to being a hindrance in any way. We just try hard at the grad school to live up to that name and to provide the best training possible. One of the challenges for us is not everyone who comes to school for us is going to work for the organization. Certainly some might choose to do that, but we've had students from 47 states, and I think over 40 countries internationally as well. So we don't have a presence in all those places. So sometimes we're generating counselors who are going to make a difference in their home communities, but not they may never work for a Hazel and Betty Ford program
Mm.
just for geographical reasons. So that's all part of it. But the other challenge, that not specific to your question, but when you think of how do you choose a graduate school? Many people choose something close to them, and these days we do have an online program, so that's sort of where people are looking. Um, but we don't have an undergraduate feeder institution. We're solely a graduate school. So we don't have those students who say, I just graduated, not really sure what I want to do, so I think I'll stick around dear old alma mater for another degree. So we don't have that. And fortunately or unfortunately, you're not going to see us on Saturday afternoons playing football against the University of Alabama or something. So we don't have that publicity that comes from intercollegiate sports, and so some of the traditional ways that universities are known don't really apply to us. On the other hand, they don't have treatment programs either, and so it is
Mm.
not uncommon for us to have someone come to our school. And I think I was telling Rashonda this the other day. I'll say to them, "Well, how'd you hear about our graduate school?" And they kind of look around. This is where stigma comes in, and they'll look around. They'll whisper a little bit, and they say, "Well, I was a patient here," and I say the same thing every time. I said, "You don't need to whisper about that. We're so pleased that your recovery has gone well, and now you're looking for a way to give back." And so for us, maybe the equivalent of the undergraduate feeder is the people who went through treatment and realized that they have something to offer, and they had a good experience in one of our treatment programs, whether it be at the Betty Ford Center in California, or we have an outpatient program in New York City. I have a location in Naples, Florida. They may have gone through treatment there, and they say, I'd like to learn how to do this work from the graduate school from where I went to treatment. It kind of gives you chills when you have that experience.
Powerful.
What a great calling card. Rashonda, we our last guest had a question for the next guest. Do you remember what it was?
I do remember one of the things, Kevin, that we do every time on this video series is we always give our cause leaders an opportunity to ask a question of the next guest, someone who is adjacent or in the same field as yours. So our previous guest has this question for you, Kevin, and it is, what does self-care look like for you? What does self-care look like for you?
Yeah. Well, it's a great question, and it can really be difficult when you bring your work home with you and you worry about your patients or your clients. And so, um, part of what self care looks like for me is transitioning mid career from being in a direct provider of clinical services to being on the academic side. Um, so I've been fortunate to move to helping to educate the counselors of tomorrow as opposed to providing the direct services. So I think as we evolve in our careers, um, I worked with adolescents in my early career, and I remember working in a hospital-based treatment unit, and the kids there would I knew their music, I knew their movies, I knew all this stuff there, I knew all their slang. I don't know any of that today. I couldn't do that, and working with adolescents is quite stressful. And so I always thank those students of ours who are willing to work with young people. Not getting exactly at your question, but I think sort of regularly assessing where you are in life and career and deciding if you need to tweak it a little bit. So I haven't made a dramatic career change, but I'm on the education side now rather than the clinical side. And I think that's a form of self-care, actually. Recognizing that for me, this is a good place for me professionally. On the personal side, I'm blessed with a partner of 38 years. That's in just in marriage, let alone before that. So having supportive people in our lives and seeking them out, spending time with them, I think is really important. And these days it's becoming easier and easier just to retreat to your own home, and you have everything at your disposal at home. You can order food, and you can shop, and you can watch movies, and a lot of the things that we used to you can go to your church services. I mean, the
Mm.
things that we used to go out for, we can do at home. So I think being intentional around spending time with supportive people, and then some physical activity too. I try to swim every day, um, and it's easy to do on the days you want to go, but making yourself be physically active on the days that you kind of don't really feel like it. Saying, I know this is important for me. So some of those things stand out for me on the self-care side.
I love it. I love it. What would be your question for our next guest?
Well, I would say what gives you hope? Not knowing who the next guest is, we all work in areas that are challenging. And when I tell people what I do, not so much now on the school side, but when I was doing more direct clinical work, people would almost always say the same thing. I don't know how you do it. That must be really depressing. And I would say, no, you don't understand. I get to be around people in recovery. What's depressing is the overdose death statistics and things like that. Thinking about people who don't get help. So, whatever your next guest is doing, I'd be curious what brings that person hope for the future. What's getting better? How do they stick with it?
Great question. Such a good conversation.
Absolutely. Kevin, I appreciate your being with us today. And I can only imagine how gratifying it is to know that um, now, instead of helping one person at a time, every student you graduate has an exponential impact on the area of substance misuse. So that must be very gratifying. And we're just happy that you could be with us today and share it. So thank you for your time. And thank you, as always, for believing in good.
Well, thanks, Kevin. Those two words, gratifying and exponential, are really really excellent ones, and I do feel both of those things. And as we move toward the end of our careers, I think it's natural to say, who's going to do this work when we're no longer doing it? And so it's one of the great things about education is the answer is right in front of you. I miss being in the classroom, but they need administrators too, and so that's what I get to do. And we're just fortunate to have a wonderful faculty and staff who are doing the direct work with our students, and I get to see them sometimes as well. I get to shake their hands as they walk across the stage at graduation, which is it's pretty awesome. So I appreciate the opportunity to talk about our school and some of the issues, and the questions you both asked were just excellent. So thank you for having me.
The Science of Good interviews support the work of For Goodness Sakes, a communications firm that uses behavioral change principles to help nonprofits and government agencies advance social causes. Learn more at fgsakes.com.